Hello, everyone. I'm Marsha Mott, the Health Promotions Coordinator for UF Health. Welcome to the UF Health Wellness University webinar. Today is World Stroke Day, and we have two incredible speakers I'm going to tell you a little bit more about. The first speaker is Dr. Anna Khanna. She's the Medical Director of the UF Health Comprehensive Stroke Program, which is part of an elite group of providers focused on quality stroke care. UF Health is a comprehensive stroke program certified by the Joint Commission. Dr. Khanna earned her bachelor's degree from Rutgers University and her medical degree at Ross University School of Medicine. She completed her internal medicine and neurological residencies at the University of Medicine and Dentistry of New Jersey. She then went on to complete her fellowship and remained on as an assistant professor and the stroke program director. Dr. Khanna moved to Florida in 2007 and joined private practice in Marion County. She then joined the faculty at UF Health as an assistant professor in neurology in 2011, where she currently provides care for stroke patients in both inpatient and outpatient settings. She also mentors stroke fellows, medical students, and residents. Dr. Khanna's main interests are in acute stroke management and continuing research in several clinical trials treating acute stroke. Our next speaker is Justin Dupray. He grew up in Manhattan Beach, California, and obtained his bachelor's degree in microbiology and immunology from the UC Irvine in 2013. Justin's interest in medicine was fostered through various extracurricular and volunteer activities throughout high school as well as college. He graduated from the Medical College of Wisconsin in 2017. During medical school, Justin developed a strong passion for neurology and is currently completing a neurological residency at the University of Florida. He is interested in pursuing a career in academic medicine, likely as a neurohospitalist. In his spare time, Justin enjoys traveling, reading, hiking, playing video games, and exploring Gainesville. If you have questions today for our speakers, you can submit written questions at any time using the Q&A button at the bottom of the screen. At the end of the presentation, I'll ask the questions that you've submitted. I also want to let you know this webinar is going to be recorded, and I will send out a link to the recording within a few days. Dr. Khanna, I'm going to go ahead and turn over to you now. Thank you.
Hi, I'm just going to share my PowerPoint here.
Okay, it looks great.
Good morning, everyone, and welcome to our presentation. Today is World Stroke Day, which is something that we celebrate, but at the same time, it's a day that we reflect on. It's a day where we learn about stroke and stroke prevention and various stroke treatment options. Someone on the planet has a stroke every 2 seconds. Before you leave today, you have to promise that you plan to practice prevention instead of having a stroke. And before you leave today, we want you to promise that you will know the signs of stroke. 1 in 4 people worldwide will have a stroke, but up to 80% of strokes can be prevented. High blood pressure is the #1 controllable risk factor for stroke. Nearly half of Americans have high blood pressure, or also known as hypertension. A normal blood pressure is 120/80. People with high blood pressure have a lower life expectancy and a higher risk of stroke. Up to 80% of strokes may be prevented if you have full control of your risk factors. 1 in 3 American adults will have high blood pressure and not even know that they have high blood pressure. If you're 50 years old and you do not have high blood pressure, you will live 5 years longer. So promise that you will work on your blood pressure, check your blood pressure, and if it is high, you will work with your doctor in order to reduce it. Each year in the United States, 795,000 people will have a stroke. A stroke occurs every 45 seconds in the US. Every 3 minutes, a stroke-related death occurs. For women between the ages of 45 and 54, you are twice as likely to have a stroke and die from a stroke than you are from breast cancer. Stroke is the 5th leading cause of death in the United States. However, it is the leading cause of disability, and there are over 4 million Americans living with neurological disabilities associated with stroke. Stroke does not discriminate by age, by gender, or by your racial background. All of these famous people that you may recognize in this picture all have had a stroke. And I would like to share this video with you because it encompasses the whole continuum of stroke. So stroke does occur. And then when you come to the hospital, initially you are treated for your stroke, but it doesn't stop there. The treatment is a full continuum where you receive medications when you first present, you receive various treatment options when you're in the hospital, you receive various diagnostic studies where we try to figure out why you've had a stroke. And after that, you receive rehab, which is just as important as the initial treatment. This is one of our patients.
When I woke up, it was devastation. My name is Steve Boehner. I'm a law enforcement officer here in Alachua County. Well, it was really a normal day, what I thought was a normal day. It was April 10th of 2017. I was getting ready for work. I was working specifically in the training bureau, and I was going to actually shoot that day. As a law enforcement officer, we train routinely. Obviously, firearms is one portion of the training, and things took a drastic turn. Literally, I was on the firing range, and I got a sensation immediately that I was getting weak, and I felt like that I was losing my strength, and my strength specifically on the left side of my body. And when that happened, I recognized pretty quick that something was very serious. I was able to reholster my firearm. I turned away to the trainers and mentioned to them that something serious had just happened to me. At that point, I lost the ability to talk. My other first responders, which I had 30 to 40 first responders with me at that time, they kind of knew what to expect, and they knew that it was likely a stroke. I was what I thought was in perfect health. I would run half marathons. You know, I was on the SWAT team at the Alachua County Sheriff's Office. So having a stroke was quite a shock.
Captain Maynard's case was unique. There's only a handful of cases that you usually remember your entire career. His is going to be one of them for me. When he came in, he immediately went into one of our resuscitation bays. You could tell that he could understand what we were asking him, but he could not form any type of logical response. This part was really concerning to me, along with his agitation and how he really was refusing care, which I don't think was his norm. And he was fighting IVs and fighting the group, and we had to take control of that situation. And the best way to do that and get that CAT scan, which is really the best way to identify a stroke syndrome, was to sedate him and give him a breathing tube and put him on a ventilator.
As soon as I arrived at the emergency room, I was escorted directly to the stroke unit. One of the first decisions that I needed to make when I arrived at the ER was to sign off to put my husband in a medically induced coma. It was a very scary situation, but reflecting back on that time, I'm so very grateful for their professionalism and the way they communicated with me. And he took quite a bit of time to show me, talk to me about the results of the CT scans and what it looked to be as far as his next step for care. Steve had an unknown and newly diagnosed
clotting condition called antiphospholipid antibody syndrome, which causes clots to form really anywhere in the body. And he had a clot that formed in an artery inside the brain and caused his stroke. Overall, he looked in a pretty poor neurological condition.
When I woke up, I wanted to communicate with my wife. I wanted to communicate with the doctors. I wanted to answer questions. And I couldn't communicate. It was gibberish that came out of my mouth. And I tried to communicate and write, and I couldn't write. The only thing that went on the piece of paper was literally just like a line, basically. It's all that came out. My ability to communicate and speech was at a level of maybe a kindergartner.
Steve had what we call is an expressive aphasia. He was able to comprehend, he was able to follow commands, but he was unable to express himself and allow people to understand what he was thinking and what he needed.
Well, emotionally, it was devastation for me. I mean, it really was. Every stroke patient is going to have some very degree of depression. The onset could be really quick. Oh my gosh, you can't read, write, or talk. It's pretty depressing. And then over a period of time, you recognize that this is not going to be like, breaking a bone. If you don't have some sort of support system in place, that's where the depression comes in. For a period of time, I didn't necessarily want to be there. And that's what happens, I think, with a stroke patient is you're not sure whether or not you really want to be here and you want to, continue on. My identity is as a law enforcement officer. I've done this for almost 25 years. I lost my identity.
I don't understand.
Now read the word.
I don't.
Rehab plays such an important role, especially in the beginning recovery stage. When Steve came to rehab and when he first saw me for speech therapy, he had a pretty severe aphasia. He was unable to read, he was unable to write. So we would practice naming pictures, we would practice describing photos.
Taller or Taller.
These patients are needing intensive therapy daily, 7 days a week, in order to recover from their stroke.
Daily, the doctor at UF Health or doctors at UF Health would show up and they would show me an object. And one of the objects that they showed me was a paperclip. And I didn't know what it was. I could see it. I understood what it was used for. I just couldn't communicate it to you. Extreme frustration on my part. After probably a week, maybe 2 weeks, when they showed me that paperclip and I was able to say, paperclip, it clicked. And it clicked, and I knew then that I could come back. And after a week of frustration and not being able to communicate, I knew I had the ability to bring it back. At that point, I knew my timeline. I knew that within a 6-month period that you're going to get most of your gains. The doctors had communicated that to me. Okay, so I've lost a week. Let's rock and roll. I'm ready.
Steve was very fortunate to have Brenda as such an incredible support system. She had past experience of being an educator and being a teacher. And so now she was using these, simplified books and activities that she was doing with her students. Now she's doing it with her husband.
I spent a lot of years teaching students with autism and teaching them how to speak and how to communicate. And so thankfully, I was able to use some of those previous skills that I had to work with my husband.
She was instrument of me coming back, and I'm here. The rehab folks at UF Health and my wife literally taught me my colors, the names of my family, of my kids, how to speak again, how to interact and communicate with the rest of the world. They helped me get my identity back. If it weren't for that support system, I don't know that I could have made it. And I hope and I pray for every other stroke patient that's out there has that support system.
He had incredible support, not only from his family, but from his work family as well.
The first responders that were around Captain Maynard had a big impact on his prognosis. And their recognition that something was wrong and getting him to our UF Health and a comprehensive stroke center impacted his potential disability.
There was a stroke team that was ready. There was an army of individuals, people that are professionals in how to take care of someone that is a stroke patient. It's not just the doctors on the stroke team. I can tell you that the compassion that I was given with the nurses, with the speech therapist who sat down hours and hours and hours to teach me to say a single word. The compassion that they gave to me, not just me, but to my wife and my family, was instrumental in me being here today. To date, I still have that paperclip. That paperclip symbolizes hope. And I have the ability to communicate back to the rest of the world. I'm communicating with you today. I'm talking with you today. I'm here, and I was able to make it and beat it. My name's Steve Maynard. I'm a survivor of a stroke, and I'm here because of UF Health.
So believe it or not, Mr. Captain Maynard still carries that paper clip, and he showed it to me. It was still in his wallet. It gives him hope, and he always brings it with him. So although a stroke can affect anybody at any age, in any gender or racial background, stroke does occur more frequently as you get older. So if you look at these graphs, if you're between the ages of 45 and 54, you can still have a stroke, but your risk is quite low. As you get older, for each decade of life, your risk of stroke increases and it actually doubles. So when you're between the ages of 75 and 85, your risk of stroke is really quite high. And that's when you have to be very vigilant about your risk factor and follow with your physicians and make sure that you're on the appropriate medications. When it comes to stroke, time is brain. When it comes to stroke, time lost is brain lost. So is stroke treatable? Yes, it is, but you have to come for treatment early. When brain cells die, they cannot be restored and they cannot be brought back. So when you see someone or yourself and you're having symptoms of a stroke, you must immediately call 911. The specific symptoms and signs that we talk about is something you probably have heard many times. We call it FACE, and this is the mnemonic. F stands for your face being droopy. A stands for your arm being weak. S stands for your speech being slurry. And T stands for time, or time to call 911. In fact, if you have 3 of these symptoms, if you have the face, arm, and speech, it's 85% chance likely that you are having a stroke. So remember face in any of these pictures: fast, fast this way, fast that way, and I'm sure that you have seen this multiple times. So let's talk about more specifically other symptoms of a stroke. Sudden onset of numbness or weakness in your face, arm, or leg, especially affecting one side of the body. Sudden trouble speaking, such as in the fast mnemonic, or understanding. Sudden trouble seeing in one eye or both eyes. Sudden trouble walking, dizziness, or balance. Sudden severe headache, or the worst headache of your life, that suggests that you may have a bleeding or a hemorrhagic stroke. And what are the risk factors we keep talking about? Well, some risk factors you cannot change, such as age. As you get older, your risk of stroke increases, as we discussed. Certain types of strokes prefer a particular gender. Race. So for example, African Americans and Asian Americans have earlier strokes, prior strokes. So if you have a history of having a stroke in the past, your risk of a second stroke increases. and family history, which are your genetics, unfortunately, you cannot change. But there are numerous risk factors that can be changed. We talked about high blood pressure or hypertension, certain heart disease abnormalities, most commonly atrial fibrillation. In fact, if you're between the ages of 80 and 89 and you have had a stroke, 23 to 25% chance that it is due to atrial fibrillation. Cigarette smoking and TIAs, or what some people know as mini strokes. So if you've had any of these symptoms, you still have to seek care and not ignore it, because you can have a stroke and your risk of stroke increases. Diabetes, high cholesterol, weight, and sedentary lifestyle. So what can you do? You have to know that stroke is a medical emergency. You have to know the symptoms that we've discussed. You have to remember fast and call 911. You have to know your risk factors, control your blood pressure, cholesterol, diabetes, don't smoke, alcohol in moderation, and daily exercise. And these are some helpful numbers from the American Stroke Association. If you need more information about stroke and you want some pamphlets, you can just go to strokeassociation.org. There's some numbers and you can connect to other people. And then there's various networks and support groups as well. And now I'm going to turn over the presentation to my esteemed neurovascular or stroke fellow, Dr. Dupray.
Okay, let me load my screen really quick. Oops. All right, here we go. Okay, so yeah, my name is Justin Dupray. I'm one of the stroke doctors that works with Dr. Khanna. So Dr. Khanna spent some time just now talking about some of the kind of a big overview of stroke and how stroke affects our lives and some of the things that we can do to try to decrease your risk of stroke. What I'm going to do is I'm going to talk a little bit more about some of the like nitty gritty of strokes. I'll be talking about like specifically what a stroke is, the types of strokes, and then the causes of stroke, and then how we treat stroke, prevent stroke. And then I'll actually finish up talking about one of the cool new advances that we have as far as treating stroke. So first of all, I want to actually define what a stroke is. So the key thing about a stroke is that it's when an area of the brain has a sudden loss of blood flow, and that causes the brain cells to die. And really one of the key things about stroke and diagnosing it for us doctors is that it's really that it has to be very, very sudden. This isn't something that happens over the course of days or weeks. It's all of a sudden that you're talking and walking fine 1 minute, and then a few seconds later you may have trouble talking, you may have weakness, numbness, vision changes, things like that. So it's really like all of a sudden like there's a blockage or some issue with the blood getting to where it needs to be, and that's what causes these stroke symptoms. Some of you may have heard of this term called TIA, which stands for transient ischemic attack. The layman's term for this is like a mini stroke. I've never been a fan of that term personally because it's a mini stroke basically makes it sound like it's a small stroke. I think a better term for it would be a temporary stroke. But a TIA is basically when you have stroke symptoms, but they actually resolve. And when we get like head imaging, we actually see that no brain cells have died. So that's the key thing to differentiate a stroke from a TIA is that a TIA, there are no actual brain cells that have died. All right, so there are two major types of stroke. The first type is an ischemic stroke. And with an ischemic stroke, what happens is you have an artery that brings blood up to the brain, and there's a blockage in that artery, like shown here in this little cartoon. And then as a result of that, all the brain cells that need blood from those arteries, they die, and that's what causes the stroke, and that's what causes your weakness. Most strokes are actually ischemic. About 80 to 85% of them are ischemic. The other type of stroke is called hemorrhagic. This happens when a blood vessel actually pops, so it actually bursts and blood actually leaks into the brain or around the brain. Only about 15 to 20% of strokes are hemorrhagic. All right, so next I'm going to talk about how we can actually see stroke on CAT scans and MRIs. So we already kind of talked about how we're able to recognize a possible stroke based on how somebody is, based on the symptoms somebody's having, like sudden onset of weakness as an example. But we can actually diagnose stroke based on CAT scans and MRIs. So here on the left, you can actually see that this is a very routine type of CAT scan that we get, where we give contrast to make the vessels light up. And you can see that, here, like all these little squiggly white lines, these are all blood vessels in this person's head. And you can see, like on this side over here, that the blood vessel looks nice and open. We can see the contrast, but then over here on this side, the artery is actually blocked off. So this is actually somebody that was having a stroke in one of the big arteries in the brain. And then we can actually get an MRI to actually see how bad the stroke is, so like what area of brain cells have actually died. Like an MRI, it gives us a much better resolution picture of the brain. And here you can actually see that on this MRI, you can actually see that all of this brain tissue has actually died as a result of that stroke. Hemorrhagic stroke looks a bit different. So we actually rely a lot on CAT scans to try to diagnose hemorrhagic strokes. So here you can see, like, this is a stroke that actually has bleeding into the brain itself. But the bleeding can also happen on the outside of the brain, which is shown here. This one on the right side is called a subarachnoid hemorrhage. But all this white stuff here, this is all blood that is outside the brain, whereas this one over here, this is blood that's inside the brain. All right, so next I'm going to talk about the different causes of ischemic stroke, and then I'll talk about the causes of hemorrhagic strokes. So there are 4 major categories that we use to classify ischemic strokes. So the first one is called large artery atherosclerosis. Atherosclerosis is just a medical word that basically just means that there's like a bunch of like fatty plaques in the arteries that just makes the arteries kind of hard. So here you can see that here, like in the carotid artery, here you have some junkiness in the artery. And over time, like over the course of months and years of high blood pressure, high cholesterol, smoking, things like that, these arteries can just become very hard and develop these like fatty plaques. And sometimes those fatty plaques can actually break off and go deeper into the brain and cause a stroke. You can also have these fatty plaques build up actually inside the head as well. So these like this large artery atherosclerosis can happen outside the brain, and then also in the vessels actually inside the brain too. The opposite of a large artery disease is called small vessel or small artery disease. So here, this is when you have something very similar. You have these plaques form, but they're on the very, very small arteries that feed the very, very deep areas of the brain. A third and very common cause is something called cardioembolism. Cardio just means heart, and embolism refers to a clot. So these are clots that come from the heart. So you have a clot that forms in the heart, and I'll kind of describe how that happens, but a clot that forms in the heart, and then from the heart, it can basically jump up and go up into the brain and cause a stroke. There are lots of different reasons that people can have cardioembolic strokes. So it's like clots coming from the heart. But one of the most common ones I want to talk to you guys about is something called atrial fibrillation. Atrial fibrillation, which is kind of shown here in this little diagram. So normally, like a normal heartbeat, you have this nice, regular, synchronized beat where like these top chambers beat and then the bottom chambers beat. So you have this very nice like lub-dub, lub-dub, lub-dub. It's very nice and regular. But with Afib, what happens is that beating becomes very irregular. And when the heartbeat becomes irregular, so you can see it kind of down here that the heartbeats are not evenly spaced like they are on the normal side. And when the heartbeat is not beating regularly, what happens is the blood flow inside the heart can become very turbulent. And when the blood flow becomes turbulent, then these little clots can form in the heart, and those clots can then go up into the brain and cause a stroke. And Afib is actually, it's an interesting condition because some people can actually jump in and out of this Afib all the time. So you can actually be normal, have a normal heart rate, and then maybe like for an hour a month or an hour a year or something like that, you can actually jump in and out of this abnormal heart rhythm. So it's not something that is, sometimes it can be very difficult to diagnose. As far as the common symptoms of AFib goes, for one thing, it can be asymptomatic. People can be walking around and not even realize that they have this going on. But some of the more common symptoms are lightheadedness or dizziness, trouble breathing, and then some people can actually feel like a fluttering sensation in their chest, which are called palpitations. And the last big category of causes of ischemic stroke is just in this kind of like random other category where we just lump all the more rarer causes. I listed some examples here. So one is something called like an arterial dissection. So a dissection occurs oftentimes after something like a trauma. But like if you imagine like if you get into a car accident and like you have some whiplash injury, it can actually damage the blood vessels and create this little flap. And this flap can then cause the artery to become kind of narrow, and it can cause blood clots to form in this area that can then cause strokes. You can also have like the blood vessels actually spasming. That's called vasospasm. This can happen for a huge number of reasons. For instance, people who unfortunately take cocaine or other stimulants like methamphetamines can actually have vasospasm, and that will clamp down the artery and actually prevent blood flow from going distal or like downstream from that artery. And then there are a bunch of other causes, like if the blood is too sticky, if there's like some reason for the blood vessels to become inflamed or swollen, that can kind of clamp down on the arteries. And then there are some rare genetic causes and a few others that I'll kind of save for now. All right, briefly, I'll go over some of the causes of hemorrhagic stroke. There are quite a few of these. Probably the most common that we see is uncontrolled blood pressure. So you can see here that just like in this picture, this person's blood pressure is over, like it's 196, like the top number, which is called the systolic blood pressure. Really, like for preventing stroke, we actually like that top number to be less than 130. But this person, it's very common for us to see patients who have very bad bleeding in their brain, and it's because their blood pressure may be over 200 or something. Aneurysms are another common cause. So here you can see basically what an aneurysm is it's when the blood vessel wall becomes a little bit weak, and then the artery starts to balloon out a little bit. And when the artery balloons out like this, this area of the artery is also weak, so it becomes more prone to bursting and causing bleeding. Then there are a bunch of other kind of rarer causes, like you can have these weird blood vessel malformations here, which these blood vessels are very weak. They're not strong like a normal blood vessel, so they are more prone to bursting. Brain tumors can bleed. Certain blood vessel diseases can bleed. And then there are a bunch of others, like of course, like if you hit your head and you have trauma to your head, that can actually cause bleeding as well. All right, so next I'm going to talk about some of the basics of how we treat stroke. So if somebody's having, all of a sudden they start having stroke symptoms, what do we exactly do for that? So Dr. Khanna already introduced this idea that time is brain. This is something that we as neurologists say all the time, time is brain. And this is because we've actually seen that that brain cells actually start dying very, very quickly when people have a stroke. So these are some kind of scary numbers, but it shows that for every second that you wait in coming in to getting treated, up to 32,000 neurons can die. And if you even wait just 1 hour, 120 million brain cells die, and that can actually increase, it can age your brain by the equivalent of about 3.5 years just by waiting an hour. So this is why it's very important to not don't sleep it off. Don't try and go to bed and hope it goes away in the morning. Like when these things happen, you have to come in immediately. Call 911. All right, so one of the first big things that we can do is, if you come in early enough, is we can give a clot busting medicine, which is called Tpa. This is it's an IV medicine, so we give it in an IV, and it's a medicine that actually breaks up blood clots. But it can only be given if you come into the hospital within 4.5 hours. So if you have the symptoms, you go to bed, you think, oh, they'll go away in the morning. By the time you wake up and you realize, oh, the symptoms aren't there, I might be having a stroke. By that point in time, it's too late for us to even consider giving you this clot busting medicine. It's not a medicine that we give very, without much thought. Like it does have a small risk of bleeding, about 5 to 6% of people. So about 1 in 20 people or so that we give this medicine to do have some form of bleeding. So it's not a medicine that we give willy-nilly, but in the appropriate population of people who come in, it can be very, very helpful. And just to kind of show you like what TPA does, and in this little cartoon down here, you can see that this is, if you imagine this being like a little blood clot with some red blood cells, these yellow things are clotting cells called platelets, and then all this white stuff is this net of clotting proteins. But TPA, this clot busting medicine, does is it basically helps to eat away at this white net, the clotting proteins, to help break open that blood clot. The next big thing that we can do potentially for ischemic strokes is something called a mechanical thrombectomy. This is where we actually have our neurosurgery colleagues go in and physically remove the clot. This one, we can only do it if the clot is in one of the big blood vessels that goes up into the brain. If it's in one of the small blood vessels, it's very difficult to actually get to those, so the surgeons aren't able to remove those clots. But we can actually remove it if it's in one of the larger arteries. This one, unlike TPA, which remember TPA can only be done within the first 4.5 hours. This one can be done up to 24 hours from when a person was last known normal. So again, like it's important to come in immediately when you have these symptoms. This little picture shows like kind of what happens. So that what they'll typically do is they'll put a catheter into the groin, and they thread that catheter all the way up, go past the heart into the up into the brain, and then they use this called a stent retriever device to basically pull out the blood clot. And I actually have down here, you can see this is a study that we get while they're doing the procedure. So here you can see that there's a blocked artery right here. And then they go in, they remove the blood clot, and you can see all of those nice arteries now filling up. So this is a person who we would presumably be able to save a lot of brain cells from dying because we were able to remove that blood clot. And then another big thing that Dr. Khanna kind of hinted on was that a big component of how we treat stroke in the hospital is early rehab. So studies have actually shown that you actually have better outcomes, you're less likely to be disabled if you have early rehab, like physical and occupational therapy as soon as possible. That's why when people are in the hospital, we work really hard at, after we try and figure out why they had the stroke, we try to focus on getting them, up and moving around, so that way they can try and recover as much of their function as possible. Before I talk about how we prevent strokes, I just wanted to briefly talk about how a blood clot is formed. This is a very, very complicated topic, but I'm just going to give you like the nitty-gritty of it. So let's say you have like a cut blood vessel, like let's say here. You can see here that you have these like little clotting cells, which are called platelets, and these clotting cells form something called a platelet plug. But this plug isn't perfect. Like there are still little teeny tiny holes in between the platelet plug. So then that's where the clotting proteins come into play. And that's shown here, like in this little net-like thing. And I actually have another diagram down here that shows it in a much higher detail, that you can see all these little, like this net-like thing. These are the clotting proteins that have activated and basically formed this like nice strong blood clot. So when we give people medicines to try and prevent strokes in the future, what we do is we try to prevent the platelets from sticking to each other, or we prevent the clotting proteins from working. So how do we prevent stroke? So this is specifically in people who have had a stroke. Like, how do we actually prevent it? So the first thing that we do is we discuss something called antithrombotic therapy. Antithrombotic just means anti-clotting. It's basically what we use to try to prevent future clots. So one thing that we can do is give an antiplatelet. This is a medicine that helps to prevent the platelets from sticking to each other. So the common ones that we use are aspirin or clopidogrel, or Plavix is the other name for it. And then sometimes we'll also give an anticoagulant. This type of medicine helps to prevent the clotting proteins, that net that I showed you, from working. The common examples, there are a ton of these, but the common ones are warfarin or Coumadin, and then apixaban or Eliquis are probably the two most commonly used ones. Ultimately, depending on which one the choice of using an antiplatelet or anticoagulant always depends on the cause of stroke, and we always determine this on a case-by-case basis. I included a little table down here, just I don't know, like just for the sake of completeness, I guess. But like, for people who have like really junky vessels, with lots of fatty plaques and stuff, we tend to give antiplatelets. If they have like Afib or other strokes coming from the heart, then we'll give an anticoagulant. But again, this is just very, very broad. We always do things on a patient-by-patient basis. Some people will actually benefit from having various procedures to prevent additional strokes. it always depends on the type of stroke that you have. But as an example, if you have like a lot of like junkiness in the carotid blood vessel, which is one of the main blood vessels that goes up into the brain, then we can actually ask our surgeons to go in and physically remove the blood clot or the blockage, or we can actually have them put a stent in to open up the blockage. Very similar to how people who have heart attacks may need stents in their heart. Sometimes we'll put stents in the carotid arteries as well. And then likewise, if people have strokes coming from the heart, in some very select cases, we'll end up doing some procedures on the heart. Like if they have a hole in the heart, we can give them a device to actually help close the heart. Or if they have atrial fibrillation, we can actually put in this little device to actually block off this little cavity in the heart that blood clots like to collect in. A big thing that Dr. Khanna really hit on was a really big thing to prevent stroke is to control the vascular risk factors, which a lot of people do by working very closely with their primary care doctors, their PCPs. So we like the blood pressure to be less than 130, the top number to be less than 130. Controlling the LDL, which is the bad cholesterol, is important as well. A lot of patients, we start on a statin medicine to help control their cholesterol. Some of you may have heard of atorvastatin or Lipitor. That's the most commonly used statin. And then hemoglobin A1C is a blood test that we use to look for diabetes. Basically just making sure that the diabetes is well controlled if people have it is also very important. And then there are lots of lifestyle modifications like, there are lots of lifestyle modifications, like there's something called the Mediterranean diet, which I'll show you on the next slide. Regular exercise, which the current recommendation is to try and get at least 40 minutes of moderate to vigorous exercise for at least 4 days per week. And then, of course, not smoking. Not only can smoking increase your risk of tons of different types of cancer, but it's also very toxic for the blood vessels, and it can actually lead to those junky blood vessels like I showed you earlier. So this is a Mediterranean diet for those of you that have never heard of it. Basically what the diet is that it focuses on like fruits and veggies, whole grains, nuts, and then fish, and with less emphasis on like chicken and milk and yogurt, things like that, and then really trying to minimize like the red meats like pork and beef. Very briefly, I'll talk about how we treat hemorrhagic strokes. This ultimately really depends on why a person had the bleeding. For most of these strokes, we do try and keep the blood pressure normal. We'll also potentially give medicines to help correct any clotting problems. So in people who, as an example, were on a blood thinner and they have a bleeding and they have bleeding in the brain, then sometimes we'll give medicines to try and reverse that blood thinner. If there's an aneurysm, then we repair the aneurysm. So here's a picture of how a surgeon can actually go in and clip the aneurysm and actually prevent the aneurysm from getting any more blood. Or they can also do something called a coiling, where they put this coiling material into the aneurysm and actually prevent blood from going into it that way. Sometimes we can fix these abnormal blood vessels. I showed you a picture of one earlier, but here's a bad, like basically a big ball of blood vessels, which is very weak and very prone to bleeding. Well, they can actually fix this, and you can actually see that this is what it looks like, much more normal compared to other people. And then certainly avoiding certain drugs and blood thinners can also be helpful in preventing or in treating these strokes as well. In very rare cases, sometimes the surgeons will actually go in and physically remove the blood. We usually don't do that unless it's really bad. And in most cases, the blood just naturally goes away over the course of weeks to months. And then we do tend to bring these people into our ICU just to keep a very close eye on them, just because bleeding tends to have more serious negative outcomes, unfortunately. So we keep a close eye on those people. Second last thing I wanted to talk to you guys about was just some of the long-term complications of stroke. So of course, when you have a stroke, only about 1 in 3 people are actually permanently disabled after a stroke. But after a stroke, you can certainly have residual weakness, vision changes, trouble talking, things like that. Spasticity, which is basically just when the muscle becomes very stiff and hard to relax, is also pretty common after a stroke. You can see here that in this little picture that if the arm is affected, that people can have this trouble where like the elbow is flexed, the wrist is flexed, and the fingers are flexed. And it can be very hard for people to relax in those cases. So it can be very difficult for those people to move the arm, in which case muscle relaxants or Botox injections can sometimes be helpful. Seizures are also a not super common, like a relatively uncommon complication of of strokes. Just as a fun fact, actually, out of all adults, if you have new onset of epilepsy, the most common cause is actually after a stroke. But fortunately, only about 5 or 6% or so of people who have had stroke actually have seizures long term. And then there are lots of others. Depression is very, very common, memory problems. And I've listed a few other ones here, but those are probably the most important like long-term side effects that we see after stroke. All right, so lastly, I wanted to end things like on a positive note. So we've kind of like emphasized how like time is brain, how it's really important to try and come in as soon as possible. Well, in recent years, like in the last decade or so, there's actually been this like strong push globally to have this thing called a mobile stroke unit. And really the idea of a mobile stroke unit is that we're bringing the hospital to the patient. So instead of having to wait to do any sort of treatment or management until you get to the hospital, now we're bringing the hospital to you. So the idea here is that it's very similar to an ambulance, but the big difference is that in that mobile stroke unit, you actually have a CAT scanner in the mobile stroke unit, and there's actually a camera and like a video capabilities so that you can actually be talking to a doctor like myself or Dr. Khanna, while like even just like outside your home, like in this mobile stroke unit. And there have been a few studies that were actually recently published that showed that using these mobile stroke units actually leads to better outcomes. So there are fewer people that end up permanently disabled with using a mobile stroke unit. And then just for fun, I have a few pictures here to show you what they look like. So these are a few other academic hospitals in the country that are already using a mobile stroke unit. But you can see that they're basically like ambulances, maybe just a little bit larger to fit the CAT scanner inside. And then, again, this is what it looks like on the inside. So here's the big CT scanner. Here's the monitor so that you can see the physician and the physician can see you. And then inside here, there would also be like paramedics and like a nurse specialized in treating stroke. I just wanted to add this too. So here, this map kind of shows where all the stroke units are in the US right now. And you can see, I've just like highlighted here that there are currently no mobile stroke units in Florida. However, one exciting thing that we're trying to do at the University of Florida is that we're actually trying to get the funding to be able to have our very own mobile stroke unit that we can have driving around and actually going to places where we can hopefully treat strokes earlier. So we are trying to fundraise. So if you are interested, or if you know any other people that may be interested in potentially donating, like please definitely reach out to us, because we'd love to get this up and running as soon as we can. And with that, I am done. And Dr. Khanna and I are happy to answer any additional questions.
All right, sounds great. That was a great presentation by both of you guys. I really, really enjoyed that. So thank you. We have had several questions come in. And here's a really good one. It came out kind of early, so I know you've talked about it a little bit, but how do you know if you're having a TIA?
So that's a good question. And initially, a TIA will look identical to a stroke. The big difference between a TIA and a stroke, like clinically, is that a TIA, the symptoms will go away, but you won't know that until the symptoms actually go away. So even if you're like, oh, this might be a TIA, like I'm having stroke symptoms, go to the hospital. Best case scenario, they resolve, the symptoms go away. But we like to say that TIAs can sometimes be warning signs of things to come. So it's, if somebody has a TIA and the symptoms go away, that's great, but that doesn't mean that the symptoms won't come back. I mean, it could mean that the next time that those symptoms happen, maybe they don't go away. So it's still important that when you have a TIA to come, even if you think that the symptoms may go away, or even if they did already go away, call 911, come to the hospital immediately, because your risk of actually having another stroke is actually highest in the first few days after having a TIA.
Okay, perfect. I forgot to ask you guys to turn off your screen share, by the way.
Oh.
You have a second to do that.
There we go. Okay.
And then another person asked, does a sudden onset of dizziness or being lightheaded, is that a sign of a stroke?
It can be, yeah. So lots of things can cause people to become suddenly dizzy. Like it can be a problem in the inner ear, but it can be a problem with the blood vessels in the back of the head too. The back of the head is where like the balance centers are. And I'm sorry, you can't really see her, but Dr. Khanna is sitting right next to me.
We're trying to figure out
Yeah.
how we can both get on camera, and it's not working out very well.
It's perfect for Halloween. You guys are kind of a little spooky, a little
Yes.
mysterious.
I'm the invisible ghost, so
Yes.
happy
Yes.
Halloween.
The invisible neurologist.
But yeah, so if you have a sudden onset of dizziness, especially like that head spinning, or like where you feel like you're spinning or the room is spinning, that definitely can be a sign of stroke. And we see patients like that all the time in the hospital. So for sure, it's definitely appropriate to come into the emergency room as soon as possible when those things happen.
Okay. Another great question. Are there any tests or procedures that you could do to know if you're prone to having an aneurysm?
So we can see aneurysms like when we get, one of the slides that I showed you earlier, like show like the blood vessels themselves as they go up into the brain. So when we give contrast to people, we can actually see if there is an aneurysm. And not all aneurysms require treatment. There have been a lot of studies that have shown that sometimes aneurysms just stay there. They don't grow, they just stay there. Other times they do grow, and then as they grow, the larger they get, the more prone they are to potentially rupturing and causing bleeding. So usually what we'll do is if there is if we do see like an aneurysm for whatever reason, a lot of times they're discovered incidentally, like just on accident, we'll find them. If we do see them accidentally, then we'll usually talk to our neurosurgery colleagues, and typically what we do is we follow them serially. So we may like get a repeat CAT scan in a certain number of months or something like that, just to see if it does grow over time.
Yeah, so most aneurysms, very few are associated with particular genetic or familiar type of conditions. Most aneurysms actually occur because of the similar risk factors we discussed. So smoking and high blood pressure or hypertension actually can lead to formation of aneurysms just because of all the stress that the blood vessels experience.
Okay, thank you. Here's another great question. With COVID-19 causing blood clots in many areas of the body, like brain, heart, and other organs, is there a way that you can help reduce this from causing a stroke, these types of blood clots?
I don't know if I should say it, but I think getting a vaccine is very important.
No, I think
because
you can say that.
The side effects of COVID, including the actual COVID disease and the post-COVID syndrome, which is associated with various things that people experience, including fatigue, tremors, shaking. There's so many problems with smelling and tasting. All of those side effects, including the actual COVID disease, are way worse than the side effects you get from a vaccine. So we definitely advocate getting the COVID vaccine to prevent it.
No, please advocate for that. I just want people to know I've been vaccinated, and I'm feel very fortunate I was able to be vaccinated. So avoiding getting COVID is, I think, the best way to prevent having that. So thank you so much. Can the amount of sleep I get at night affect my chances of having a stroke?
I think so in two ways. So there's no direct correlation. So for example, if somebody sleeps 2 hours, 3 hours a night, they're definitely going to have a stroke. There's no direct relationship that way. However, things like sleep apnea, if you have sleep apnea and you stop breathing at night and you're not getting enough oxygen to the brain, that is a risk factor for both stroke and heart attacks as well. So making sure that you don't have sleep apnea, and if you do, getting on the machine called the CPAP machine and getting it titrated properly by a sleep lab is very important to prevent both stroke and heart disease.
Okay, thank you. There have been reports in the news recently that taking baby aspirin every day is a waste of time as a preventative for stroke. Could you comment on that?
So there have been lots and lots of studies that have actually shown that that's not the case. So we give baby aspirin all the time to prevent stroke. So like we've actually have like clinical data to show that your risk of stroke is actually less if you take a stroke or if you take an aspirin compared to if you don't. So we give aspirin very routinely for most of our stroke patients, if not a stronger version of that.
Okay.
And I
Um,
think Dr. Dupray is also referring to people that have had a stroke. So if you've had a stroke, you've had a TIA, you have a heart condition or what we call cardiovascular disease, then we call that secondary prevention. That's after the event, and you have to have an aspirin or an aspirin-like medication.
Okay, so, I assume that if you have questions before you want to start doing anything like that, you should consult maybe your primary care doctor or whoever's caring for you for those other conditions. Is that a good
Absolutely.
starting point? Okay.
Absolutely.
And then I received a question. I'm not sure exactly if this is a thing, but is there something called an eye stroke? And could you talk about that?
There is. So there is a stroke equivalent in the eye. It's called a central retinal artery occlusion. But basically there are blood vessels that come off of the carotid artery that go to the eye. And if those get blocked off, then you'll have sudden vision loss in one eye. So and we treat it as if it's a stroke, but it's essentially a stroke equivalent of the eye.
Okay, I didn't know about that one. And then someone asked a question. I've seen in the paper, I've seen other places advertised like a thing called like a lifeline screening, where maybe you go to a mobile bus, you pay $100 for a whole battery of tests. Someone asked, can that help detect a stroke? So I know usually a lot of time they're doing like a carotid artery scan, they're checking your blood pressure and cholesterol and things like that. Would something like that be able to help look at your risk for stroke?
Yeah, so Lifeline is, it's a national program. I think it's very good, but it's not very specific to treatment. So what happens with these programs, you go to an area where they do ultrasound of your neck for your looking at your carotid arteries. They also do other kind of screening. And they can actually, and we've seen people where they pick up a blockage in the carotid artery. And then with that, they don't provide any treatments. With that, they give you the report, and then you present that to your primary care physician or your neurologist or your cardiologist, whomever you follow with. And usually what we wind up doing is rescanning to make sure that the test was a valid test. But I think the program is great. You do have to pay for it. I don't recall exactly if insurances cover it or it's a cash payout, but it definitely can give you like a screening. And then with that, you can seek medical attention, and then we can take it from there.
Okay, well, that was great. Is there anything either of our speakers want to add, or is a follow-up or anything? I don't have any more questions out there, so. Oh, well, thank you guys so much for speaking today and taking time to present this on, especially on World Stroke Day, so that we can all learn more about the signs and symptoms of stroke, and know that we need to call 911 and not take a nap and think about how I feel when I wake up, because it's something that time is so important for. So thank you guys so much for taking time out of your busy day. Thank you for all that you do. And I thank everyone who took the time to attend today. Thank you very much.
Thank you,
Thank
everyone.
you.
Stay healthy.